and a warm welcome from the offices of IAT Germany. My name is Nando Gauss. I'm working here as an Innovation and Project Manager in the German Co-Location Center. And I'm here with you today to take you through this Meet the Innovators session. Talking about our offices here, we are located at the campus of our partner Roche in Mannheim, and Roche is actually the coordinator of the innovation project behind our session's topic, which is Integrated Personalized Diabetes Management. IPDM-Go is the project behind that. And I've been accompanying this project from IAT Health side since its beginning, so I'm especially delighted to see it highlighted here at our IAT Health Summit. And now, please let me introduce our speaker for this session, Klaus Kramer Peterson. He's project manager at the Department of Health Technology at the Danish DTU University. And he's also a project member, a part of the IPDM-Go project, working there on the development of an adaptive patient assessment tool as part of the integrated solution. And now in his presentation for the next quarter hour, he will give us an insight into the IPDM-Go concept and in their journey towards better health outcomes in diabetes care, especially for type 2 diabetes. And before I now hand over to Klaus, please be reminded to post your questions in the Q&A chat here at the bottom of your Zoom window. And we will have then some minutes at the end to answer them. And now, thank you for that. And without much further ado, Klaus, please, the floor is all yours.
Thank you very much. So I'm here to present the Integrated Personalized Diabetes Management Goes Europe project. We are focusing on co-creating approaches for better outcomes for people with type 2 diabetes. I will, in this presentation, give a short introduction to the background of the project. I will put most of the emphasis on the tool that we have developed to support a new patient pathway for people with type 2 diabetes. And in the end, I'll just say a few words about what the future steps are for the project towards implementing the solution using a value-based healthcare model in practice. So a little bit of background. So diabetes in Europe is inflicting about 58 million people. It causes around 500,000 deaths per year, and the costs incurred on healthcare systems are to the extent of 160 billion euros annually. A very large proportion of this is due to type 2 diabetes. Type 2 diabetes is very lifestyle dependent, oftentimes requires less treatment than type 1 diabetes, but it's very much focused on lifestyle and thus also more prone to intervention in other ways than a classical clinical intervention, perhaps. So multiple studies have shown suboptimal diabetes management demonstrated across different European countries. Some of the recommended treatments are to have 3 to 4 annual visits with an HCP to measure HbA1c, the long-term blood glucose level, which is a strong indicator for how you are managing your diabetes. Only about 50% achieve this target. And if you also include the full guideline recommended treatment, including blood pressure and cholesterol measures, only about 7% meet these goals. Further, there are clinical trials that demonstrate impressive results in lowering HbA1c levels using a combination of drugs and interventions. However, there is a gap between what the results that these clinical trials can show and what real life or real world effectiveness demonstrates later on. And oftentimes this is caused by these studies involving a large number of interventions aside from the drug, such as coaching or advice on diet, that sort of thing, which is not sustainable in a real world context, at least in not everywhere. So to address this, the IPDM cycle, Integrated Personalized Diabetes Management cycle, was proposed as a way to provide a simpler structure to the way people manage their diabetes, focusing on blood glucose, providing some steps and some training to how to measure blood glucose, how to remember it, how to structure it, make it available for the HCP, and for the HCP to be able to discuss this more openly with the person with diabetes. A study was done that did show improvements in blood glucose and perhaps more importantly also in patient satisfaction, largely due to patients being happy to be put more in focus and be able to talk more about their diabetes rather than feeling that they are a disease that the HCP needs to treat with their classical instruments or means. So to those of you who saw the morning session, there was the exact quote that we have as a premise for our project in the session with Peter DeBay from Santion, where he included an interview with a person who had diabetes for 46 years, and for that amount of time did not feel that he had actually been asked about what he feels about his diabetes, and he appreciated that greatly. And that is also what we're aiming to do with this project. The value-based healthcare perspective is of course also important because this study of the IPDM showed that it can be cost effective. And since this is a supplementary treatment usually to existing, it's necessary to show a cost-benefit analysis in another way when you cannot replace existing treatment in order to convince commissioners of using this solution, for example. So the overall goal of the IPDM Go project is to co-create and implement the IPDM cycle in a specific subpopulation in a Danish context to enhance the IPDM cycle using digital tools to take advantage of recent developments in technology, to co-create a value-based healthcare contract in the Danish context, and to pilot this to show the full model. Now, the consortium is led by Roche Diabetes Care and also consists of a Danish region and municipality, aside from a range of public and private research institutions, including the Technical University of Denmark, where I'm from. So the part of the project that we are leading is on the development of this adaptive patient assessment tool to be used between the person with diabetes and the HCP. We call this DiaFocus, and this is a tool for doing digital phenotyping of the individual, meaning the actual behavioral the behavior demonstrated, the activities done by the individual person, as opposed to genotype data, which is reliant on your genes. So phenotyping is about the demonstrated behavior. We also sort of expand the focus to do it more holistic by also including an assessment of psychosocial status that includes a focus on well-being and mood and perhaps feelings of anxiety in relation to diabetes type 2, because this is very important to diabetes management. Then we are seeking to improve this further by including predictive modeling based on both genotype and phenotype data to be able to stratify and predict how the individual person might be best supported or treated for their diabetes, for example, by investigating risks of comorbidities. And then the platform should also support a shared decision making and a focus on value in the sense that the person with diabetes should also be allowed to express their feelings about diabetes in combination with the focus on clinical outcomes. So very short about how we have developed the system. It's been a co-creation process, meaning iterations of development of the software platform, along with people with type 2 diabetes, HCPs, researchers, commercial actors, and other experts. We're just finalizing a feasibility study and are starting a clinical pilot next month. At an overall, this DiaFocus system consists of a smartphone-based app to be used by the person with type 2 diabetes. Then there's a web portal for the HCP user to access information from the smartphone. And then there's a cloud-based secured backend that stores and synchronizes data between the other elements. So here is the adapted or the IPDM cycle use case in the case of DiaFocus. So if we look at step number 1, there's an initial discussion between the HCP and the person with diabetes about what they would like to focus on for the next period or until the next consultation. And keep in mind, the time between consultations is typically 3 to 4 months. So then they move on to step number 2, where the person with diabetes, him or herself, types in their focus areas and their plan by themselves. And this plan consists of some concrete actionable activities. So for example, go for a walk every day after dinner, or make sure to stay in contact with your friends and relatives, even if you don't feel well, to emphasize, for example, a focus on well-being or avoiding depression, for example, or social isolation. Step 3, this is the long period of time between consultations, for example, 3 months, where the person with diabetes uses the smartphone app daily by answering questionnaires, input data, and keep a diary. And prior to the consultation, the app pushes out a questionnaire about what they would like to talk about and focus on in the next consultation. Then step number 4 describes how the HCP accesses the web portal, generates a PDF report that basically summarizes the data from the smartphone app. All the data is there except for the diary notes, which are kept private because it's a diary. So these diary notes can be accessed on the smartphone and can be used by the person with diabetes during the consultation, for example, in step number 5. So a combination of the report and the data in the smartphone app will then allow a more holistic perspective of focus of discussion between the HCP and the person with diabetes. And of course, as shown in step number 6, there's also still room for, of course, focusing on the clinical guidelines on HbA1c and blood pressure or whatever is deemed relevant by the HCP. And then the cycle repeats by formulating a new set of focus areas and making a new plan, or repeating certain focus areas depending on how they have assessed that the progress has been since last time. So just overall, the features of the system is that there's the psychosocial assessment on, for example, well-being, anxiety, lifestyle. There's behavioral and health data, the digital phenotyping, including activity, location. These are important indicators for how people are doing and are being collected in order to be able to build these predictive models in the future. There's a clear definition of focus or a customization for the individual to the extent that they themselves, the person with diabetes, makes their goal. They write in their own diary and they write down their own considerations for the HCP. And then the HCP report provides a basis for this structured communication based on the data and not only what can be recalled, for example, during a consultation. So this screen shows a few examples of screenshots from DiaFocus. On the right-hand side, you can see some color-coded boxes that shows the user how they're doing in certain areas. They can see cards for the data they're typing in and that is being collected on the phone automatically. And they can go in and type in diary notes and rate how they're doing. On the left-hand side, you can see an example of the report to the HCP. And for example, it shows an easily accessible overview of, for example, how a user has responded to the WHO-5 questionnaire on well-being. It shows the individual responses to the the questions, and also the calculated total score, and uses some color codes to assist the HCP in quickly interpreting these results, so that it reflects the reality and that the HCP has very little time often with the person with diabetes, both in preparation, if any, but also during the consultation. So just to draw out a few comments or insights from the users testing the solution. So the users are optimistic, and they would like to share their feelings and their well-being, and to have that focus in their discussion with the HCP. But some are perhaps a bit cautious, or would like to are perhaps a bit doubtful whether their HCP can handle that discussion. So that's something we'll definitely are very interested in looking into once we start the clinical trial and get the full cycle in progress. Another main point here is also that the people with diabetes greatly appreciate being able to collect their information in one place and get an overview of what their diabetes is, and how, for example, maybe their well-being is related to their weight or their smoking or their mood in general. For example, we also hear from people who had type 2 diabetes for 20 years that they would have loved to have something like this, especially when they were newly diagnosed, because if you don't manage your diabetes well in the beginning, sometimes you won't feel the consequences until 15, 20 years after, and maybe you need to have a foot amputated or something worse. So they would really like this tool to help build some good habits and a good behavior that is more adherent also to the clinical guidelines from the beginning of being diagnosed. So another aspect of this project is the data modeling, the predictive modeling. So we also have a part of the project working on a data set, a large data set analyzing the individual risk of comorbid conditions. And these algorithms resulting from this part of the project will be integrated with the solution I just showed later on, to be able to make it even more personalized to the individual by combining genotype and phenotype data. And then just to summarize or to finalize the presentation, I'll just say a few things about the next steps in the project towards implementing the solution in a value-based healthcare context. So we have a number of learnings from this project. So the people with type 2 diabetes are very different and need to be treated as so in their plans. We believe that the shared decision-making also needs to be made on the basis of the individual's behavioral habits, metabolism, for example, psychosocial status, which is also why it's important to improve these predictive models to be used in the future to improve this further. And to do this, we need to do more data analysis, which is the target for the project. And we also need to understand the costs better and do more health economic analyses. And right now we are conducting another pilot to negotiate a value-based contract in a North Zealand context, using the solution I just showed, along with a negotiation with the healthcare providers on how to test this, by first identifying the right subpopulation and then taking steps further from there. So just very briefly to summarize, we are 2 years into a 3-year project, and we are working to make a value-based contract within the coming year. We have a number of steps on the way that I've already gone into, so I won't spend too much time on that, but I'm very happy to take questions and have a discussion. So thank you.
Thank you, Klaus, for this great presentation and the insights you provided. And if you're happy to take questions, you can be happy that we have already 4 of them. So let's start right away. The first one is rather a bit technical, maybe. Does your platform offer doctor-patient communication and data collection, for example, for high blood pressure, as high blood pressure is also an issue for diabetics?
Yeah, so the communication is done indirectly through the generation of these reports. There's no tool to provide direct communication. That's something we would have to test to determine whether that's something to do. In a Danish context, it's probably not realistic as is. Blood pressure. So the platform we have built Diafocus on allows integration to a large range of devices. For example, blood glucose measurement devices, which we are using also for the clinical pilot. So there's nothing against integrating to, for example, a Bluetooth connected blood pressure measurement device, and build that in as an extra feature. And that's indeed something we have already received some feedback and desires to have implemented. So that's something we're in the process of evaluating and prioritizing which elements to include.
Mm-hmm. Okay, and the next one, with regards to implementation and let's say the willingness to adapt, a user wants to know, or audience here wants to know, how do you experience the openness to VBHC at hospitals and at solution provider level? And is it maybe tricky to assess the added value of such a solution if you have a complex system with multiple interventions and healthcare personnel, etc., etc.?
Yes. Indeed, yes, it is very complex. It's a long journey to negotiate, especially in a Danish context that is perhaps 99% public and only 1% private. So we need to negotiate these against some large public actors, and we need to have some very convincing cost-benefit analyses and documentation of the project. So in the clinical pilot we're starting now, we're also using some standard patient-reported outcomes, quality of life questionnaires to support documenting and demonstrating the value we can provide. In regards to the first part of the question about how the openness towards it, I think perhaps there's a in Denmark at least there's a skepticism towards this the word value-based, because some HCPs feel that they did not. I mean, if we call this value-based, did we not provide value before? So I think that there is a little bit of a task in demonstrating what these kinds of solutions would actually do and how they could also improve the HCP's way of working and their practice. So it takes some, let's say, getting used to some explanation to demonstrate this. But once they can see how this can support for example, their regular consultation with people with type 2 diabetes, then they seem to greatly appreciate it. Yeah, and then of course there's a need for doing more health economic analyses also to document this in the future. It's no simple task.
Mm-hmm. I think, yeah, that's quite obvious. Good. The next two questions are maybe coming from the same person, the way they were asked. So they're around superlatives of what would be the biggest challenge in designing a user-friendly platform for the end users, and also what are the biggest needs of patients and HCPs, which are the end users, with your platform?
So the solution we're building right now addresses people with type 2 diabetes, and of the people who have been testing it so far, they have been ranging between 40 and 80 years old. So obviously there are different needs and also different IT competences in the user group. So we have tried to build it as simple and as user-friendly as possible. But we also want to try to find the balance between also allowing the, let's say, the interested user to be able to modify and customize the solution to a high degree if they feel that would provide them value. So that's actually something we're working on right now to negotiate that and find that balance between how much personalization or how simple should it be on the one and the other side. But the co-creation process helps us here because we collect information continuously about this and adapt to that. So.
Mm-hmm. Okay, I hope that answers those two questions. And now we have very limited time left. So maybe just a quick one on what are your thoughts about scalability beyond the pilot size to a larger patient population, also beyond Denmark?
Yes. So in itself, the software solution is extremely scalable. I think the largest barrier to scaling to other countries is, of course, negotiating the reimbursement models with the relevant healthcare providers or insurance companies or whatever relevant payers are there. So that's probably the largest barrier. And then we are also aware that there will, of course, be some both regional and national differences in how both patients with diabetes, but also the HCPs would prefer to treat and so on. It is a rather customizable platform. So from a technical perspective, that might not be the largest issue, but of course it would take some work to, I mean, we can't just copy paste to all countries, probably, but we don't know yet, but we don't expect to be able to do so. But it's mostly about negotiating I believe the contract that would be the largest barrier.
Okay. So Klaus, I think we are reaching the end. That was the last of our 3 IPDM Go sessions for today. Thank you very much for having time passing by our EITF Summit. Thank you, audience, for contributing with your questions and your comments. And this session, or the nicest of the 3 ones, is being uploaded on the EITF Summit platform later on today or latest tomorrow. You can review it then. And for now, I'd like to say goodbye to all of you and have a nice day wherever you are.
Thank you.
Stay healthy.
Thank you for the question.
Bye-bye.
Bye.